To the radiology department today, after our visit. It's in room 120. Have you been there before?
Yes.
Okay, so you're on the 4th floor. You would just go downstairs to room 120 and inform them that you've not been called, and so you can get a schedule.
Okay.
Okay, if there's an issue with that for some reason, let me know. Okay.
Okay.
We're going to give you all our information, our contact information in this clinic. Okay. So I'm going to ask you a couple questions, but before I do, just to kind of give you that overview, right? So the idea would be to proceed with the treatment, which would be administered to you once every 2 weeks. So it's a cocktail of medicines, and we're gonna, before you leave today, we're gonna set up another consultation appointment, and that's when you come back with your mom, and you meet with our chemotherapy certified teaching nurse, and she goes over the name of the drugs and the side effects. We don't just take the person and start them on the therapy without any knowledge of what these drugs are and what they do to their body. And chemotherapy is a scary word, right? Because people already have some kind of some perception of what chemotherapy represents. Maybe they've read something about it, seen a movie, had a family member, a friend with a family who's been impacted. And so, but what I want to stress is everyone's experience with chemotherapy is unique unto themselves, right? And generally speaking, young people tend to tolerate chemotherapy better than elderly patients. So you have that in your favor, okay? Especially because you're not dealing with other medical conditions. So when I have an elderly patient with cancer, they frequently have other medical problems, right? Whether it's diabetes, high blood pressure, cholesterol issues. And so those factors have an impact as far as how well they deal with the chemotherapy, okay? So the idea is there's a regimen, and there's going to be a lot of different terms thrown at you, and just like we have Tylenol and Advil, we have drugs for oncology, for cancer cure, and the name of this cocktail is referred to as FLOT, F-L-O-T. This is the FLOT regimen. Every cancer has its own recipe, its own regimen, right? So this regimen consists of 3 main drugs. And basically, I'm just using Monday as an arbitrary example. We would first need to send you the radiology for a procedure where they would place a port, and I'll show you what that looks like. It's a little device that goes underneath your collarbone, and then we remove it. It's a catheter. It's an IV device, and I'll show you what it looks like momentarily. So you would get that device placed. It's a same-day procedure. There's no hospitalization. I mean, you have to come to the hospital to have the device placed, but you don't have to be admitted overnight for that. It takes a few hours of your time. And then you would be discharged, and then we can use the device even the next day. Okay, it's going to have a bandage on it, and then we'll be monitoring for healing with the device, because then they'll do a stitching on top of the skin. So let's say Monday is your first day, right? You'll come to our clinic here. We'll show you the infusion center to receive your cocktail of medications. You'll be here approximately 4 to 5 hours, okay, on a Monday. Sometimes up to 6 hours depending on the infusion, okay? And then you'll be discharged home. And when you're discharged home, we're going to give you a little device that looks like a cartridge, like let's say a larger version of a phone, okay? Thicker than a phone, and it's going to contain one of the chemotherapy drugs in it, okay? It's going to be in a little bag, let's say the size a little larger than your phone with that case. And you can carry it like in a little bag, very light, or it's like a fanny pack, you can wrap it around. And basically, that's going to infuse one of the drugs for 48 hours, technically 46 hours, okay? Continuously. So you're here on Monday for that, let's say, 4 to 5 hour period. You're going to go home with that cartridge. It's going to have one of the drugs in there running for 46 hours, okay? You don't do anything, it's just running, okay? And it's attached to the line. Obviously, those two particular days, you can't go jogging or hiking or anything like that. You have to kind of just chill, right? You can of course move and walk and everything. And then on Wednesday, 2 days later, right, when you come back, they're just going to dislodge you from the port, so you have nothing hanging from you, okay? But when you come back on Wednesday, it's what we call a business day or administrative day. It's only 5 minutes. You're not here another 5 hours, right? So we say one cycle. That's what it is. Once every 2 weeks, right? We have to do that 8 times. So it's 16 weeks or 4 months if there are no delays, okay? So that means 8 total sessions, right? Once every 2 weeks. So that first period with us is a 4-month interval, okay? And so we do all the chemotherapy up front, and then the goal is surgery. Now in very specific scenarios, after we re-image you, right? Because we have to take all the pictures again after we finish, right? Some patients may require radiation before surgery, but that's very few, okay? Just letting you know. But so radiation probably is never going to have a role in your treatment, okay? So after the chemotherapy, then the next phase would be the surgery, and then you're done. There's no chemotherapy requirement after surgery. So the bulk of your work is these 4 months, okay? So, and sometimes there are delays, right? If you come down with a urinary tract infection, right? Or if your blood counts are too low, because we have to check your blood counts before every treatment, right? And so sometimes the 16 weeks can become 18 weeks or 20 weeks, right? But not because of lengthening of the treatment, just delays. Delays can happen. So, but basically you're coming once every 2 weeks. The Monday, for example, is the mega session. When you come back 2 days later, it's just to get dislodged from the port. You go home. That's it. Once every 2 weeks. Does that make sense?
Yes.
That's how the regimen will work. Now, why are we doing this? The reason we're doing this is because in the past, like let's say 5 to 7 years ago, up to 5 to 7 years ago, patients were going and receiving upfront surgery, right, removing the stomach. And in the field of oncology, in this particular area, we started to see that patients were relapsing. That means the cancer was returning even though the stomach was already removed in a very short interval. And the reason finally was that basically microscopic cells could be in that area, lurking around, right? So if you go and just take the stomach out right now without sterilizing that area, microscopic cells could be left behind. That's why we were not having the good results, right? So the field decided to change and give the chemotherapy first and then surgery. So that does two things. One, it tests the sensitivity of the tumor. Because if a cancer grows, because it can happen, it's not common at all, but if a cancer breaks through chemotherapy, that means that that's a cancer that has a poor prognosis. That patient will not get the surgery, unfortunately, okay? So we want to be very positive, and I want to point out all the possibilities in front of you. The major possibility being, and a realistic possibility, to cure you. Yes, we have to take you through the process, but as I said, we want to cure you. This is not a situation where we're just trying to slow things down. No, okay? But, so what we're doing, number one, giving the chemotherapy up front, we are testing the sensitivity of this cancer, okay? And number two, we are preventing metastases, right? So if a microscopic cell is lurking and ready to flower, so to speak, or sprout, we're in essence trying to kill that and really cleanse that area before the stomach is taken out. So that's called sterilization, right? Just like washing your hands, right? Before cooking or before any activity, right? So that is in essence what the purpose of chemotherapy is. And then once that strategy was compared to the prior strategy, this strategy won out by a wide margin, and patients we were having better outcomes in the field of gastric cancer, right? So now the standard of care is in the United States, chemotherapy first, then surgery, okay? So that's why we're doing it in this fashion, just so you're aware. And we're gonna watch you throughout this process. It's not, we have a team, right? So whenever you come, just like being the new kid in school, the first time, it takes some time to acclimate, right? To adjust. And so you're gonna see our nurses. Our nurse is gonna inquire about how you've done with the regimen that week. So you're gonna be, so you have a set of eyes on you twice that week, right? When you're coming in for therapy. So when you return to pump 2 days later, then, if you're dehydrated, we can give you intravenous fluids. If you need help with anti-nausea medicines, we can give you anti-nausea medicines, intravenously, I should say. And so that supportive framework is there. Okay? Does that make sense so far?
Yeah.
So that's the treatment. Okay, so we're going to give you an appointment. That's when you come back to learn about this regimen called FLOT, flat. Okay, that's what you're going to receive for 8 total times up front. Okay, once every 2 weeks. And then you do need a port. So let me show you. Let me bring the computer on. Show you what a port looks like. And the reason we use this is because you're going to have a continuous infusion, right? And there's an option between a port, which is this device that goes underneath the skin, underneath the clavicle, the collarbone, versus a PICC line. So a PICC line is like a standard IV. You know, if you've been seeing people hospitalized, it's a 2 or 3 pronged IV. And the problem with the PICC line, it's more convenient, it's faster to get the PICC line in, but the problem is it requires dressing changes once a week, okay? And number 2, it has a higher risk of infection because that 2 or 3 prong line is outside. So then the patient has to be extra careful, right? And there's a higher chance of the PICC falling out. You just inadvertently, you're doing something, a task, you know, you can pull it. So it's a hassle. So it's always better to do the port, and then the port can be removed after you're done. Okay. It's not it doesn't stay in your body permanently. Okay.
Okay.
So.
And that occurs, you said. So each time I come, they have to do that.
No, it's a one-time
it's just
procedure.
one time.
Yeah, it's a one-time procedure. So this is what a port looks like. It's got a port, right, with a catheter. Okay. So this is an example. You go to the radiology department. They make a small incision, okay, and they put this device underneath the skin, okay, and then this goes into one of the large veins, and then basically the nurses access this from the outside, okay, and that's how you get the chemotherapy, so it doesn't burn your veins. Does that make sense?
Yes.
So I'll give you an example. So like for example, let's get this. So this is what it looks like. Okay, there's different colors. It doesn't matter. They do the same thing, and so in essence, what it is when this is underneath your skin, the catheter is going to a large vein, okay? And this is your collarbone. It sits right below your collarbone, okay? And so, like after it's well healed, this is what it looks like. There's a protrusion under the skin. You see, there's going to be a small scar there. It's going to heal, but there's a little small scar there. And then, you know, you get the port. And this is the catheter, and that's how the nurse accesses that. Okay, so that's called the port. The radiology department is going to place that for you. Okay. So that's the second thing, and then so we want to do that. We want to get the PET scan, and we want to set you up for the teaching. Okay.
Okay.
So I have all the information here, but just briefly, in your own words, tell me, you know, when were you last well, and what happened, and what precipitated this? Even though I have the report, I just want to always hear from the patient.
Okay. Just to begin with, though, may I ask, is there a stage for this? What I have?
Yeah. So you have a stage 1B. It's an early stage. Okay. We have stage 1, 2, 3, 4. Then we have 1A, 1B, 1C, and then 2. So this is still a very early stage gastric cancer, and that's why we are commenting on the fact that our goal is to cure you, right? So for example, someone who has a stage 4 cancer of any sort, we're talking stomach here, so let's use stomach as an example. So if a patient comes to me for the first time and they have the stomach cancer that's now moved, right? Unfortunately, it's traveled to the liver or traveled to the lungs, then that's deemed to be a stage 4 cancer, and so cure is no longer possible, containment is, right? So then we give chemotherapy to try to prolong that person's life indefinitely. So that they need more than 8 cycles, right? In order to keep them alive. We cycle them through various treatments, and so that's a different story, right? The reason right now, based on the CAT scan you had on the 30th of September, there is no evidence of metastases anywhere. We like to do the PET scan just as a 100% complementary assessment of what that area is looking like.
Okay, and I know the last time I did the endoscopic ultrasound with the same day surgery where they inflated, they cut me.
Yeah.
And they
diagnostic laparoscopy
yes.
with Dr. Leonardi. Yeah.
Yes. I read, they hadn't called me, but I did read that they took another biopsy or something regarding I think the fundus and what is the other word? I'm not sure, but basically where the ulcer is located.
Yeah.
So I just want to ask, is it just that one tumor ulcer that's there, or is there anything else around?
So that's the area. Have you seen any of the imaging studies?
No, I have not.
I'm going to show you one of the imaging studies. So I'll show you where that area is in a moment. Right now, 1 second.
Okay.
So yes, your biopsy was from the gastric ulcer, and that's what we saw where the cancer was. So the one ulcer, the one large bleeding ulcer.
Right.
Yeah.
Okay. Okay.
But I'm gonna show you the picture.
Okay. May I take a picture when you show me?
Of course. So let me just show you the whole. I'll tell you what to take a picture of. So this is you lying flat on the examination table for the CAT scan. Okay. This is your right lung. This is your left lung. This is your heart. This is where your head is on the examination table. This is your spine. Okay. So you're lying flat like that. Okay. Just imagine like a baguette, right? And you're getting ready to cut the baguette. So the images are basically slices of your body in 2 millimeter increments. Okay. So everything is okay there, all right? So we're going to come down to the stomach. I want to show you what we're talking about. So this is your liver right here, okay? On the lower right side. This is your spleen, which is in the left lower side of your body, which and the major immune organ as an adult, okay? This area, this is the stomach now, okay? Right here. This is your stomach right here, okay? So what is the problem here? You see this degree of thickening here?
Yeah.
This is abnormal. This is the cancer, right? So this thickening is not normal. The stomach should have this layer. The layer should be this thin, right? But see, as you come here, this is just a contrast. Remember, you require a contrast. That's just a contrast agent going through your stomach. But see, it should be thin. But here you can see this area is thicker. This area is much thicker than this area, right? And so the rim of the stomach should be very thin. I'm showing you a different angle, like this thin. This is how thin it should be. But as you can see here, it's not that thin. Look how thick it is here, right? So so that's what we're looking for. We're looking to see. You can take a picture of that. So this is called gastric. I'll put the pointer on it. Gastric wall thickening. Okay. All right. And so the idea is when we between the repeat imaging. Is the thickness the same, which is still okay, it's the same. We don't want to see increasing thickness, right? That means the treatment is not working. That means the cancer is resisting it, right? Nor do we want to see traveling of the cancer anywhere else. That's the premise behind chemotherapy. So those are the two most important points. And so if we see a regression, this thickness decreasing, that's what we're looking for. But if we don't see it, that's still okay, as long as we're not seeing metastases, which means movement, right? The last thing we want to see is movement from here to one of the primary sites that stomach cancer likes to go to is the liver, because look at the proximity. This is the liver, right? This is the stomach right here. There's close proximity, so that's what we're trying to. We don't want to see that.
Okay.
Does that make sense?
Yes.
So and just tell me how did this come to be?
Actually, 2020, I had black stool. I mean, I think this began since 2020. I had black stool and
consistently, or how many episodes?
No, just like once, maybe twice.
Okay.
And I went into the ER here at Kaiser, and they saw that it was, the doctor went in through my rectal and saw that it was bleeding. So he said, okay, they took me in for 3 days and they did an endoscopic, they did an endoscopy. And they said, oh, well, the bleeding's not coming from your stomach, well, the inside, your small intestine. They're like, so we have to go ahead and do a colonoscopy to see the large intestine. Although when I tried, so they took me out as an outpatient now to do the colonoscopy. And when they did that, they said you have to come get tested and make sure that, you don't have COVID. Okay. So when I would go do my test, unfortunately, it was always positive, but I had no symptoms. Like I was fine. So I was like, okay. So that literally delayed me. And then I got pregnant with my youngest son, who's only 9 months today. And I had him this year, January. So literally till March 29th or 26th, I did the colonoscopy. And they sent me home and they said, hey, it's just hemorrhoids, like external and internal. Okay, that's fine. So then on September 16th, I was at my grandma's house and I felt like my stomach upset. And then I had to go use the restroom and I knew it was going to be like, loose. So I went in the restroom and as I was having the loose stool, it was black, literally tart black, super black. And as I was having that bowel movement, I felt nauseous. I had to throw up. So as I grabbed the bucket, I was just throwing up and I saw blood. And right there and then I felt lightheaded. I felt a lot go through my body. So we called 911 and then they took me to Centinela Hospital. That's the nearest hospital near me. And as I went in, I guess my heart, my blood pressure was a little bit low and my heart was I was like, okay, whatever. So then I called Kaiser, made the appointment. I believe it was the 23rd or the 20th when they did me the endoscopy here. And that's when he took the biopsy. He did tell me you have a really large ulcer. And I did tell him as well, why didn't they see this 2020 when you guys first did me the endoscopy? And he said, well, first, I wasn't your doctor. Second, maybe you didn't have it. I don't know. So then I was like, okay, well, I guess now I have. And then he did say, though, that, well, no. So then they took the biopsy. And then on the 28th of September, he called me and he said, hey, we do see that you do have that bacteria, the H. pylori. So we're going to go ahead and treat that for 2 weeks. Take that medication, and then also unfortunately we did find cancerous cells, and that's where he left me. And that's when he told me, we're gonna do an endoscopic ultrasound, which just happened, and to see the waves, I believe, in there, and how we're gonna do the CT, which I had done, and then they did the other surgery where they saw that the outside of my stomach, and that's all I've gotten.
I see. Okay. Yeah, I reviewed your EGD from June 10th, 2020, the endoscopy that you had, and it was actually normal, the one from June 10th, 2020. So, is it possible that something was brewing back then and hadn't yet manifested, where they could see something with the camera? Because, I see that they looked at everything, they took pictures, everything was normal actually. So this wasn't, I'm not saying that microscopically it wasn't there, it could have been there microscopically, but it just, based on the current technology, it wasn't picked up. Yeah, so, but again, I see the entire report from it, and I saw that procedure done. Tell me this, the last 2 years, obviously you've had a pregnancy and then a successful one, correct? You said your son is 9 months old, so congratulations.
Thank you.
What was your lifestyle like? Any adverse lifestyle features, heavy consumption of alcohol, anything like that?
No. The thing that I would do.
Did you have a healthy lifestyle? Would you label it as generally healthy?
Yeah, very healthy.
Okay. So
and I really took care of myself in my pregnancy, and
you've been pregnant one time?
No, twice.
Twice. Yeah. How many children?
I have 2 kids.
You have 2 kids. Okay.
Yeah.
And then what's the age of your other child?
My oldest is 3 years old.
Okay.
He was born 2019.
Okay. So you have 2 boys.
Yes.
Okay. All right. And so you've had a healthy lifestyle, and any family history of first-degree relatives with gastrointestinal cancer of any sort?
My grandfather, I know that he had some sort of cancer, but he had right here in the esophagus. I believe my dad's dad. Yes, my dad's dad.
But your father, this has never
No.
happened. You yourself?
No.
Any other siblings with health problems?
No.
How many children do you have?
We're 4. They're 4.
They're 4, and everyone is healthy.
Yes.
Okay.
I know it's kind of early to ask, but how do you see it, like, in the future? I know it's early to know because of stage, and we want to see if the chemo works. Have you had any patients similar to Andrea's situation, and did they survive, or did it grow, or do you have something similar to her?
Yeah. So the reason I asked about the family history was because